Can you hear me?
Yeah. Yes,
okay,
we
fine.
can.
She was 56 years old when she represented. It was multiple joint pain and deformity since also 15 years of their period. Knee pain since last 10 years. So previous that multiple joint pain was there in foot, ankle, elbow, everywhere. But main pain started in the last 10 years. Difficulty in walking since last 2 years. She was managing to walk. Now not able to stand on single leg without help and support. So on examination, I found at that time the right knee FFD of 5 degree and varus deformity of 40 degree. And left side, it was valgus deformity of 40 degree and 5 degree recurrent deformity. Range of movement was painful and restricted to almost fraction of 80 degree only. So this was the clinical pictures. Right side, it is varus deformity, left side valgus deformity. Each leg standing. Both legs standing, she was able to stand without support of other people. But you see the foot, elbow, all other joints, they are deformed and they are also affected. This is full length X-ray showing a varus and valgus almost 40 degree on either side, valgus as well as varus. So these are the pictures taken in detail at that time. We can see that almost it is full deformity and full flares on both sides. One side varus, second side valgus. So this is a single stage surgery done on both sides together, and correction was achieved on table, on full correction on both sides, valgus as well as varus on left and right side. Now this is the thing I have done. So it was on right side. I have to do a sliding medial epicondyle osteotomy to correct the varus deformity at that time, which is fixed with a screw, and only tibial rods are used. The femur seems to be good. So at that time I kept it everything ready, but I have done only rod fixation in the tibial part. At that time the correction was achieved on table on both sides togetherly. So if you see, because of the medial sliding femoral epicondyle osteotomy, I can correct the varus deformity at the same sitting on right side also. This is the lateral views of that patient. These are the clinical pictures of 2 days before, standing on one leg, right side as well as left side. And this is the video of patient walking after 3 years of surgery.
Harshad bhai, excellent result.
Thank you, sir. Nice. So this is the procedure I have done. So this is regarding the all. See the deformity correction as I was walking. She is coming from front side also. So this was the correction achieved after surgery and during present time also.
So as she was rheumatoid with probably very soft bones, what
Yes.
were the special precautions that you had to take during surgery?
Each stage I was afraid of fracture. So especially the femoral fractures, because in right side especially there was flexion deformity. So while correcting it, I had to cut the distal femur more. But while doing that time, if I do more, then sliding osteotomy of femoral epicondyle may not be possible as such. So only posterior release was done, and gradual corrections, like Hemant Bhai told previously, that you go step by step. So whenever you correct it, every exact time when you feel that it is now corrected, you can have fixation of that. So even after that also, there was deformity on medial side, so that I have done epicondyle osteotomy on right side. And left side, it was all right because of the valgus, and I have been able to correct it.
I also saw that there is a lot of foot deformity also.
Yes, yes.
So I would actually, just 1 minute, I would ask Guruva and Hemant also, because I remember my time in UK, we were correcting a lot of these feet also by doing metatarsal osteotomies and MTP excisions. Is anybody doing this commonly here?
Can I just...
I've never done 1 foot, Vikram, in the last 20 years. So,
Zero.
Okay.
They had just done this.
Actually, see, this same story with me as well. I have done around some 47 cases and published in Birmingham. After coming here, done 5 in last 10 years.
I think it is because we don't wear, shoes. Our people.
I think their priority is different. That's why.
Yes, the patient priority was with knee only rather than foot. So even we advise that you get the corrected food, then they said, no, this is okay. I am happy with this.
But
So now she is not ready for any surgery.
having said that, Neelan, 10 to 15% patients post TKR, even 2-3 years afterwards, they will come and complain pain in the ankles.
Right.
Yeah, but we can't do anything. Just tell them it will go off. I don't want to touch any more feet at all. Yeah.
If you have time, I can present another case.
Yeah, you got one more case?
Yes, sir.
Yeah, good, good.
That was selected by Dr. Naran. My this one.
Neelan, he is the last presenter, right?
Yes, yes.
Yeah. He's the last presenter.
Okay.
So I am going to present another case. She is 60 years of old when she is presented with pain in both knees since 4 years. History of left unit TKR done, unit replacement done before 5 years. So when she was almost 55 years of age, left side was operated for uni. Abnormal sensation of something popping out and in with often locking of the left knee with pain. So getting relief after pressing it backward with some clicking sound. So this is a typical complaint of the patients that after surgery almost 1 or 2 years went good, but since 2-3 years I am finding that is locking off and on. At that time I had done the anti-door test, was negative, but varus valgus strain opens the left joint with some click sound. So that gave me idea of thinking that it may be going in wrong way. So this was the X-ray I took at that time. Right side, say primary ONE, left side it was with some tilt of the base plate of unicondylar medial side. And if you see the dot of that all polyethylene insert, it is going medially upward. So each time when she goes to flexion and extension, that movement occurs in each flexion and extension movements. So in further also lateral view, if you see it is going posteriorly. When it goes, when it comes in flexion, it comes anteriorly. So this was the situation of movement in each time. And if you see in detail, that polyethylene insert is going almost on the outer side at about midway of that part. So this was failing. Gradually it was deepening in down, and that gives more pain to the patient. So these are the clinical photograph of the patients, right side as the left side, single leg standing also. So on right side I have done the primary TKR. On left side I have inserted one road because I was feeling that the gap which was created because of the tilting of the tibial part. So that will be going more stress on that. So I have extended the road so that it gives support to the metaphyseal part to the almost diaphyseal part. So that's why I have done on that side with the road, and that side without road. So this is the picture after doing say replacement on right side primarily, and left side removing the uni as a whole and doing the replacement on left side. Only tibial extended road was used. Otherwise, femoral component was some simple like other primary knee. So this was the cases which I have done in a two part. So one is regarding rheumatoid arthritis. I can see with after uni.
In this uni case, why do you think it failed so early?
Maybe she is very active, almost for 2-3 years. And second thing, I don't have any immediate post-operative X-rays, but I think that the whatever implant which is kept at that time, it was some in tilted positions. That may be the reason I perceive.
Yes, the malalignment is the most common reason,
Yes.
and one of the reason is the commonest is the tibial medial plateau failing because of the stress fracture kind of thing. That's why they advise not to put too many pins on the medial side. Make
Right.
sure that it is in good alignment, not much of pins, so that it will not get a stress injury under the subchondral area.
Right. So this
Well done.
completes my presentation. I thank you, Guru Reddy sir.